Hello, Facebook and Twitter. We are excited to have you guys here today. I have joining me Dr. Pamela W. Smith and Nat Jones, our PCCA Clinical Pharmacist. And my name is Renee Prescott. I'm Director of Education and Training at PCCA. And we just finished day one of our Autoimmune and Pain Symposium. We had a great lineup of speakers, and we wanted to share some of that with you guys today. So, Pam, let me have you introduce yourself and share a little bit with our audience about who you are and what you do.
Hi, I'm Dr. Pamela Smith. I'm a physician. We have offices in Michigan and Florida. We're called the Center for Personalized Medicine. I also teach at the Morisani College of Medicine at the University of South Florida. And I've been practicing for 40 years. Very excited to be here today. And autoimmune diseases is literally one of my very favorite topics.
And Nat, how about you?
Well, I'm a pharmacist. I have been a pharmacist for 40 years. Let's see, I used to have a store, a compounding pharmacy for 20 years in Virginia. I've been a fellow with the International Academy of Compounding Pharmacists since 2010. Started working here at PCCA a little over 5 years ago, and get to be one of the clinical compounding specialists so that we can answer questions to our members on a regular basis. Technical difficulties.
Always happens when we go live, right?
Right.
All right, so I guess maybe you guys didn't hear me. We had a little bit of sound check issues. So welcome to all of you guys joining us on Facebook Live and Twitter. We just finished day one of our Autoimmune and Pain Symposium. So lots of great information presented, and we wanted to bring some of that to our Facebook Live and Twitter Live audience so they could share a little bit about what everybody else learned today. So I do have just kind of a few questions for you guys to kick it off and get us started, and then you guys are welcome to just share and have some dialogue with each other too. So Dr. Smith, what are some of the main causes of the increase in prevalence in autoimmune conditions?
Well, there's really honestly many different reasons that we now have more autoimmune diseases than we used to. When I first started practicing, there was under 40 autoimmune diseases. There's now 105 of them. So a lot of different ones. And the causes are a myriad of things, from toxins in the environment to how people eat to plasticizers. There's really a number of reasons why we have more autoimmune diseases, including even infection.
Mm-hmm. Mm-hmm. So we do want this to be interactive with our audience. So if you guys have questions for either Dr. Smith or Nat, you can, if you're on Facebook, you can just enter those in the comment section. And then if you're on Twitter, then you can just do hashtag PCCA Live, and we will get those and ask them. So one of the things that you mentioned today in your talk was the newest autoimmune condition that's been, I guess, named or classified that way. Can you share a little bit about that?
Yes, the 105th is chronic Lyme disease. And it's interesting because Lyme is a spirochete. And the only other spirochete that we're aware of is looking at syphilis. And syphilis has been, quote unquote, eradicated from the United States for a long time. But I did see syphilis when I was a very young doctor, and Lyme behaves the same way. So if you don't treat it when you initially develop the disease process, it can become dormant and it hides in the body. So literally, it's kind of like a Klingon from Star Trek. It hides itself away, and you do have to do a number of things to try and fix it. But because it is an autoimmune disease, we start with three things that we start with all autoimmune diseases. We have the patient not eat gluten. We fix their gut, because everybody with an autoimmune disease, their gut is not as healthy as it could be. So we do a gut health test, and we fix the gut. 70% of the immune system is in the GI tract. And then we do put them on compounded low dose naltrexone to decrease the inflammatory process. And then with Lyme, we treat the disease itself as an infection.
So low dose naltrexone, Nat, I know that that's near and dear to your heart. Can you share a little bit with our audience about the benefits of LDN and maybe different compounding opportunities with that?
Sure. Benefit-wise, I mean, LDN, I've been calling it the drug of the decade for about the last 2 years. I think it has so many applications. In fact, the 105 autoimmune diseases, it applies to all of those, but altogether, I think I've seen 153 indications for low-dose naltrexone thus far. So it's across the board beneficial for a number of disease states because it has multiple mechanisms. And even when you change the dose, the mechanism changes. So it's dose dependent in a lot of cases as well. The research that's coming out is blossoming. I think there's a lot of good research coming out on LDN and or naltrexone across the board. So we're seeing application for everything from opioid withdrawal to psoriasis and things of that nature because it works in so many different ways. The big thing I think in terms of like autoimmune diseases is it's affecting the toll-like receptors, TLR4 receptors. So we're seeing a decrease in the production of cytokines and the messaging that goes out through the body, and it hits the microglial cells as well. So you're hitting macrophages, you're hitting a whole number of immune mediator cells that it decreases the inflammation. So it's got far-reaching implications, and for pain as well. I mean, we're going to talk about that on Saturday with the pain presentation. So I think that the number of options for low-dose naltrexone is huge. If you're not compounding low-dose naltrexone, you're missing the boat. The presentation I'm doing Saturday, I'm going to give some information about how to go about growing your low-dose naltrexone business. So stay tuned for that if you're coming to the conference or listening to it on live stream. And I think that there's the potential for growth is amazing because nobody is manufacturing this, and a pharmaceutical company is not manufacturing it. So it's really in the hands of compounders. We have a great opportunity as compounding pharmacists to take the lead on this in terms of providing this to our patients for a myriad of disease states and indications. So it's to me, it's exciting, very, very exciting. And
are you guys utilizing this both orally and transdermally for your autoimmune patients?
Orally, mostly for autoimmune, but we're using it not necessarily transdermally, but we're using it in our derm preps that we're using to treat some of these dermatologic autoimmune disease states, and it's very beneficial. It's like you can use it orally depending on the disease. I think it may be more specific to apply it to the site of action for some patients in some cases, but certainly orally would be beneficial to pretty much everybody, and because it affects the gut. And anything that helps improve gut health and help restore the gut is going to be a positive thing for autoimmune disease, especially. I'm a big fan of oral for autoimmune, but for dermatologic conditions, if it's something where you're trying to either treat the inflammatory pain process, neuropathic pain, or you're trying to use it for a specific derm condition, I think topical would be a better choice. It can be done transdermally. We've done it for transdermal autistic patients for a number of years. I mean, I was doing that probably back in 2005, first time I saw a transdermal low-dose naltrexone for an autistic child. Okay. So
for our autoimmune conditions, primarily oral. So Dr. Smith, how do you prescribe LDN? We always get questions all the time about what's the dose. So as a prescriber, what is the dosing?
The most common dose used worldwide is oral, although I do use oral and transdermal, and the dose does have to be ramped up. So the most common dosage is starting at compounded LDN, 1.5 milligrams, 1 hour before bedtime for the first week. The patient takes 2 pills, so they're on 3 milligrams for week 2. And then week 3, they're taking 3 pills, so 4.5 milligrams. And then the last time after that, we write another prescription for 4.5, which is what people with an autoimmune disease, they stay on forever. There's no indication to stop the LDN, and except for if they start a narcotic for one reason or another. So I recently had to stop in a patient who had to have surgery, but she's going to go back on the LDN. It was very beneficial for her psoriasis. In her case, I actually used it orally, and it worked very well because she had psoriasis everywhere. Plus, she also had psoriatic arthritis, which is one of the 10 autoimmune diseases that can be life-threatening. So for her, I chose to give it orally.
Okay. So when we were talking today about the incidence of autoimmune conditions and it's more prevalent in women than men, can you elaborate on why that might be?
Absolutely. Women have a different immune system than men do. And so for women, because they're born to have babies, or if they choose to have children, their immune system needs to change so they can carry the baby to term. The baby to them is literally a foreign body. If their immune system did not change, then what would end up happening is they would miscarry every time. And because their immune system changes, they do have to have, they have an increase in autoimmune diseases because it's just not the same as males.
Fascinating.
It is fascinating.
Especially when you look at something like Hashimoto's, it's far more prevalent in females than males.
It is. With Hashimoto's, 70% of hypothyroidism is an autoimmune process. It is Hashimoto's, and so huge prevalence is certainly number one. And then, of course, lupus, rheumatoid arthritis, some of the harder autoimmune diseases to deal with are much more common in females than they are in males.
So I thought I'd just take a few minutes and go through a little bit about some of the autoimmune conditions that we talked about during the seminar today, and just have you share a little bit about each of those conditions. So we first started with ALS. So if you can share just kind of a little bit of information about that, and then we'll go down the agenda.
ALS is probably the hardest autoimmune disease I treat because as a disease process itself, there is not a lot to offer. There's one medication that's used. It's not entirely successful, and neither are metabolic therapies either. So it's one where we, again, start with no gluten at all. We fix the gut. We start low dose naltrexone, and then there's a few vitamin therapies that are somewhat successful. ALS is hard compared to many disease processes. When it comes to other things that we looked at today, MS, there's a lot of different therapies, both conventional and from a metabolic personalized medicine approach, from nutrients to diet. When it comes to MS, very important not to eat red meat, not to have dairy products, so we start there. Sometimes we have medication, sometimes we don't. There are many nutrients, particularly vitamin D, that are very important for MS. And believe it or not, we do use estrogen, estriol E3, for both men and women when it comes to MS. So it's the only time I prescribe estrogen for males is if they have MS. Some great studies from the Journal of Neurology and related medical journals.
So, Nat, your presentation today was on dermatological aspects of autoimmunity. What was, as you were doing your research for the presentation, what's some really cool ahas that you came upon?
I don't know about ahas, but one of the topics was Bullous Pemphigoid. I'd never presented on Bullous Pemphigoid before, so the learning curve was kind of steep on that, and I learned a lot about the physiology behind it, and I just find it fascinating, all the various physiologic mechanisms involved in it. It turns out that the disease itself, the immune function, is attacking the connective tissue that holds the base membrane to the layers of the epidermal to the dermal region. It's attacking that filament that holds the desmosomes together. In fact, they did a fluorescein stain. I showed the slide today. They did a fluorescein stain of the protein, and it just right straight along the base membrane. You can see where that just accumulates, and those immunoglobulins are attacking the base membrane. So it's kind of very specific sort of a thing, and it involves a calcium pump, which is kind of cool. And one of the things that I learned, I put a formula together about maybe 2.5 years ago for this, is that magnesium can help repair the pump process so you don't get the production of the immunoglobulin. So it helps protect the desmosomes in between. So we put together a couple new magnesium formulas for this seminar with W06. And we did combinations with naltrexone involved in mast cell stabilizers, things like that. So we've got some good formulas that we put together for the seminar.
Great.
Yeah, that was kind of a neat thing to learn. Like I said, I learn every day in this job of mine. I get to read, which is marvelous because I love learning, and getting ready to do a presentation, I get to create new formulas. So it's I mean, you know, for a guy who just likes to be a clinical pharmacist, that's right up my alley. So a lot of fun, really enjoyable. So.
Cool. So for those of you that are listening to us live, if you have any questions, go ahead and you can write those in the comment section on Facebook or on Twitter. Do hashtag PCCA Live, and we'll be happy to ask our presenters those questions that you might have.
We actually had a question come in, Renee, from Ashley, who is asking Dr. Smith, as a patient, how can I check my gut health?
That's a great question. My favorite gut health test is a GI effects test. It's made by a company called Genova, and you can have a pharmacist order that for you, or you can see a practitioner that's trained in anti-aging medicine and metabolic nutritional therapies. So it's a great test. It looks at infection, it looks at inflammation, it looks at deficiencies and insufficiencies. I honestly, in all the patients that I've had for these many years with autoimmune diseases, I've never had a single patient who had a normal gut health test that has an autoimmune disease.
Wow.
Yeah, that is a wow.
So permeability is a overriding theme.
It is an overriding theme, and I think a lot of it does have to do with gluten. I've had a few patients who stopped gluten before they met me, and so their GI health is better than people that were continuing on with gluten and didn't stop it until we actually did the gut health test to show that.
All right. So let's chat a little bit about Graves and Hashimoto's. So that was another topic for our seminar today. What are just kind of some highlights of those two autoimmune conditions?
Well, from looking at the viewpoint of Hashimoto's thyroiditis and Graves, they're both related to the thyroid. And Hashimoto's is hypothyroidism, or it is just an attack on the thyroid gland with normal thyroid function. Graves is hyperthyroidism as an autoimmune process, an attack on the thyroid gland. Probably one of the overwhelming things that's very new that we're looking at when it comes to testing is to do adequate testing with the thyroid. You do have to measure TSH. You have to look at free T3, free T4, reverse T3, and thyroid antibodies. Reverse T3 is rarely looked at, and it's important because it's stored thyroid, and it competes with free T3. They're on the same receptor sites, so it's important to look at reverse T3 as well. If it's not normal, then if the patient's already on thyroid medicine, you can add T3, you can lower T4, but it also tells us about mitochondrial function. And usually the mitochondria are not working as well as they could. So we have to refuel it. How do we do that? Nice, simple formula that I love because there's a lot of science behind this. We look at magnesium at 400 to 600 milligrams as magnesium glycinate or threonate. We also look at coenzyme Q10, 300 to 400 milligrams, alpha lipoic acid at 300 to 400 milligrams, L-carnitine at 1,000 to 2,000 milligrams. There is a caveat to L-carnitine nowadays with the new science. And I love PCCA because we really do keep up with the science. And so we look at the idea now at measuring TMAO levels, which is a blood study. It can be done at any basic lab, LabCorp, Quest, any major hospital. If the patient has a high TMAO, then we cannot give them carnitine as a supplement. Those people should not eat red meat. They should not have eggs. And there's a discussion in the medical literature if they should have phosphatidylcholine or not as well, because egg yolks have choline in them. So more to come on that subject. So for the people that can have L-carnitine, part of the fueling source, got to refuel the mitochondria, D-ribose 15 grams, and NADH 10 milligrams twice a day. So helping reverse T3, if it's high normal or if it's elevated, then we do go back and help refuel the mitochondria. Very important for an autoimmune process.
So you mentioned magnesium glycinate as an option. Why do you prefer that form of magnesium versus other ones that might be more commonly seen in the supplements?
It tends to get into the body better in an autoimmune patient, and it tends to have a more calming effect. Magnesium has many functions in the body. It affects many different enzymes. So we do choose different forms depending on what we're trying to do with it.
Okay, great. Let's see. So then I think the final piece that we had today was a little bit on adrenal health, which is obviously a huge part of most patients, but particularly autoimmune patients. And we had, I know that wasn't your presentation today, but you're very familiar with that topic. And if you wanted to share a little bit about adrenals and the role that plays in autoimmunity.
It does. In fact, even when you look at thyroid, we always look at adrenal health first before we would give someone thyroid medication if they need it. I mean, who isn't stressed in today's society? Everybody is. Everybody's going Mach 10 with their hair on fire. So for one thing, slow down and enjoy life. Multivitamin is key for adrenal health because the adrenal glands require 11 different nutrients to work well, and most of those are in a multivitamin. If cortisol's too high or too low, we like to do relaxation techniques. So prayer, meditation, tai chi, yoga, qigong, exercise, massage, breathing techniques, acupuncture. Find something that really works as a calming technique. When we say exercise, that does not mean hot yoga for this particular purpose. It does mean a more calming exercise, but that's key. We do give adaptogenic herbs like ashwagandha, ginseng, and rhodiola. We can also give calming herbs if the patient has a lot of anxiety and things where they feel they need a calming. So lemon balm, chamomile. It does take about a year to really improve adrenal health. When the patient's first stressed, cortisol elevates. When they stay stressed for a long time, it becomes too low. The patient continues to be stressed, then they may set up an autoimmune response, because you can, to the adrenal glands, have an autoimmune response as well. Same thing if you have an autoimmune response. We take the patient off of gluten, we fix their gut, start low dose naltrexone, even if it's an autoimmune antibodies positive in the adrenal glands.
So obviously with all of these conditions, we're looking at not only medications, but supplements and mind, body, and lifestyle changes. So all of these patients, there's a lot of other things that they can utilize to benefit their health in addition to what they might typically get from a traditional physician.
Absolutely. We probably should mention that pharmaceuticals actually come in different grades. And when we look at it from a medical purpose, we always use pharmaceutical grade nutrients, which means two things. One, it's bioavailable, it gets into the body and does what it's supposed to do, and it's also guaranteed to be 100% pure. Can you comment more on that from a pharmacist viewpoint?
Well, I think that obviously quality, it makes a difference in terms of, and particle size, things like that have a big difference in terms of absorption and bioavailability. Source of ingredient when it comes to supplements, I think, is key. And it's like anything else. It's like when we vet our vendors for our APIs that we sell to our members, it's all about the quality. It has to be about the quality. So as a basic premise, yes, and it makes a huge difference. I was going to comment on one thing you and I had talked about earlier, and that is that patients who have like an autoimmune disease like multiple sclerosis, for example, I asked the question, do you see a hypocortisolism in these patients? I never treated an MS patient who didn't have low cortisol issues. I mean, really, it was extremely prevalent. And I never treated an MS patient that didn't have hormone dysfunction either. I don't think I saw them. Male and female patients, both, they all came in. They were flatlining on their cortisols. They had very low testosterone levels. I mean, it was very, very common. It almost didn't matter the age of the patient. They would all have low support from a hormonal perspective across the board. So I think these patients have a lot of needs in terms of, in general, the adrenal and basic hormone support and thyroid support across the board. They're all challenged hormonally, which to me was a big piece of how to help them feel better. I mean, it made a big difference in terms of treating them, in terms of the outcome. And that was a huge, for compounding pharmacists, that's a great opportunity to be able to apply things for the adrenal dysfunction and hormone replacement therapy. Those are good ways you can help almost every autoimmune patient that walks in your door. At least test them to find out where because you always have to test, right? So,
if you ask me how many patients I've seen in my personal practice this year with normal cortisol, one, because it is a crazy world.
Yeah.
People are stressed all the time, and when people will tell me, oh, I'm not stressed, I really don't have stress. But if you measure cortisol, you will find out how stressful it is. Saliva testing is the gold standard for measuring cortisol.
And you know, so much, we didn't even intend to talk about hormones right now, but it keeps coming up, and that's something that we realized as we were putting together this event for the weekend is, wow, so many of our members, they have hormone patients, and that's a big part of your practices, right? And the autoimmune just tied in so nicely to that. What a great way to expand and grow your pharmacy is by helping these autoimmune patients. And just, you know, from what you said at the beginning, wow, the prevalence so high. There's so many patients that could benefit from compounding and compounding pharmacists.
Renee, we had a question come in from Twitter, and it's for Nat. The question is, what are some of your favorite publications or ways to keep up with innovations related to compounding for autoimmune diseases?
Oh, wow. Publication-wise, for those of you that don't know what I do, I basically live on the internet every day. PubMed is always open in at least 2 or 3 different places on my computer. I read abstracts daily, studies daily. There's not a day that goes by that I'm not researching. So that's literally, the internet is really where I go to get most of my current information, because the medical literature is burgeoning. It's going so fast you can hardly keep up. So it's like, you know, you can know a little bit about everything, but you need to focus on 1 or 2 areas. So if it's something you're really interested in, just constantly go back and see what's new. At least once a month you need to go back and research a topic if you want to stay current. Because the number of articles that get published on, for example, Low Dose Naltrexone, I think somebody they went back and searched from 1971 until the present, and there were something like over 10,000 articles published since 1971 on Low Dose Naltrexone.
Wow.
Yeah, I mean, so how do you filter through all that and narrow it down to what's important, you know? So, yeah, it just takes some time, constant reading. Yeah.
All right, Sarah, do we have anything else?
Yeah, I think we're going to wrap up with one final question that just came in from Facebook from Christine. She asks, if I want to find a provider in my area, so if they're outside of your area, Dr. Smith, how would I go about this? Do you recommend speaking to my physician or a compounding pharmacist or someone else?
Number one, you can always ask your compounding pharmacist. They are a wealth of information. They will have practitioners they work with all the time, or you're certainly welcome to email me at faafm63@yahoo.com, and we can give you a list of qualified practitioners that are fellowship trained or have a master's degree in this field.
Well, I think that's going to wrap it up for the night. I want to thank our experts, Dr. Smith and Nat, for joining us. We're looking forward to a great day 2 tomorrow, so thank you all for joining us live tonight, and have a great rest of your evening.